Thank you, Sama, for the excellent presentation. Now, the next paper is from Surgical Unit 2, and the title of presentation is Early versus Interval Laparoscopic Cholecystectomy in Acute Cholecystitis. Presenter of the paper is Ariba Naseer. He is final year student. Please welcome Ariba Naseer.
Hemorrhage, bile, p-value equal to or less than 0.05 was considered significant statistically. Comparing the results of the research, comparison of the operative timing, individuals from the group 1 and 9 individuals from the group 2 have less than 60 minutes of the operative timing. 5 patients of the group 1 and 16 patients of the group 2 have operative timing of 1 to 2 hours. The mean and standard deviation of group 1 is 43.8 into 11.2 and that of group 2 is 62.68 into 12.38. P-value was less than 0.05, which is significant. Comparing the operative complications, 8 patients of the group 1 and 7 patients of the group 2 have hemorrhage. Failure to proceed, 3 patients of the group 1 and 2 patients of the group 2 have failure to proceed with surgery and converting into open cholecystectomy. The p-value was more than 0.05, which is not significant. Comparing the operative complications, hemorrhage. Comparing the operative complications, nausea and vomiting was seen 6 patients of the group 1 and 5 of the group 2. 3 patients of the group 1 and 5 patients of the group 2 have surgical site infection. P-value was more than 0.05, which is not significant. Proceeding towards the discussion, cholelithiasis is a common surgical disorder. There are many complications associated with this disorder. The most common complication is acute cholecystitis. There are various risk factors associated with acute cholecystitis. However, acute cholecystitis may predispose surgeons to a difficult dissection due to adhesions at the callus triangle. There are 2 different strategies to cope with this condition. The optimum management for cholecystitis results in less complications. A prospective study was designed to compare the two groups in managing acute cholecystitis. The early cholecystectomy performed within the 72 hours of the onset of the symptoms of the acute cholecystitis was found to be a better strategy than the patient in the acute cholecystitis. Study compared the results of the early versus interval cholecystectomy in terms of operative timing, operative and post-operative complications, and hospital stay. In our study, the mean operative timing in the group 1 was 53.8 into 11.2 minutes, whereas in group 2, the mean operative timing was 62.68 into 12.38 minutes. It was found that there is a significant difference in the operative timing of both the groups. This is opposite to the study conducted by Ben Saleh et al. The study also compared the results of the two groups in the terms of the hospital stay. The mean duration of stay in group 1 was 1.41 into 2 days. However, the mean duration of stay in hospital in group 2 was 1.88 into 2.4 days. The patients in the group 1 had lower hospital stay 0.05, which is significant and statistically proved. The 2 groups were also compared with reference to the operative and post-operative complications. The operative and post-operative complications, it's not safe. The surgical site infection was found in 3 patients in the group 1 and 5 patients in the group 2. No patients in the group 1 had post-operative bowel discharge, whereas it was found in 1 patient in the group 1, which was settled within the 3 days. The study is conducted by Agarwal S and Shikata S for similar observation. Now concluding the research presentation, early laparoscopic cholecystectomy is performed quickly and is cost-effective. Early cholecystectomy results in shorter hospital stay. There is insignificant difference in operative and post-operative complications in both early as well as laparoscopic cholecystectomy. These are the references. Thank you.
Thank you, Ariba Naseer. Now the next paper is by the ENT department, and the topic of presentation is comparative study of endoscopy versus rhinoscopy. The presenter is Aisha Hamid. Please come on stage for your presentation. This is the last presentation by this section.
hair drying. Welcome to a new dimension of beauty. My name is Aisha Amir Basra, and I am here to present my research regarding comparative study of endoscopic external dactyl systems. Before I get into the crux of my research, I'd like to briefly go over the anatomy of the lacrimal drainage pathway. The lacrimal drainage pathway consists of the lacrimal puncta, canaliculi, nasolacrimal sac, and the nasolacrimal duct, which opens in the inferior meatus of the lateral wall of the nose. Any obstruction in this pathway can lead to watery eyes, also known as epiphora. Primary acquired obstruction due to chronic inflammation results in fibrosis, stenosis, and closure of the duct muscle. All of these can be relieved by dacryocesarostomy, also known as DCR. Our study was an interventional study which took place at Upstate Medical Trust Hospital from February 1st, 2017 until January 31st, 2020 on 80 lacrimal systems of 80 patients. Our group of 80 patients were divided by randomization into groups of 2 by 40-40. Patients with isolated lacrimal duct were included, while those with canaliculi obstruction were excluded from our study. Data was collected at multiple intervals and analyzed using SPSS version 22. Success in our research was defined as complete epiphora of our eyes and complete patency of the nasolacrimal duct upon the 1-year follow-up. Informed consent was obtained and IRB approval was also gained. Genders and all ages. We looked at different surgical outcomes. There were 2 parameters of the success of our research. The first one being complete relief of epiphora. As surgical outcomes were observed at different time intervals, the first one being the 7th day, where 90% of patients who had gone external DCR, 90% of patients who had undergone external DCR displayed complete relief of epiphora. However, 95% of those patients who had gone through endoscopic DCR displayed complete relief of epiphora. A p-value of 0.03 was generated, which is statistically significant. At our next follow-up after a month, 87.5% of patients who had gone through external DCR showed complete relief of epiphora. Meanwhile, 95% of those patients who had faced endoscopic DCR highlighted complete relief of epiphora. A statistically significant p-value of 0.02 was noted. When observing patients at our 3rd-month follow-up, 87.5% of patients who had faced external DCR displayed complete relief of epiphora. On the other hand, 9% of those patients who had chosen endoscopic DCR as their treatment showed with complete relief of epiphora. A statistically significant p-value of 0.02 was noted. At our 6-month follow-up, 85% of patients who had undergone external DCR showed complete relief of epiphora. On the other hand, 92.5% of patients of endoscopic DCR depicted with complete relief of epiphora. A statistically significant p-value of 0.03 was generated. Finally, at our 1-year follow-up, 82.5% of patients who had chosen external DCR as their treatment manifested complete relief of epiphora, while on the other hand, a total of 92.5% of patients who had gone under endoscopic DCR showed complete relief of epiphora. A p-value of 0.02 was generated, which is also statistically significant. When looking at a second parameter of success of our research, which is patency of the nasolacrimal duct upon staging at the 1-year follow-up, external DCR patients only showed 92.5% of patients, while those who underwent endoscopic DCR, a total of 100% achieved complete patency upon staging. In this slide, we look at the comparative analysis of literature review versus research findings. As we delved into the research done by Lake and colleagues in 2019, we found incongruence between our research findings and theirs. As we paid attention to Saha et al. In 2013, the conducted, it was evident there was a harmonious finding between our conclusions and theirs. Lastly, when we looked at the research done by Sue in 2018, we found credence which gave credence to our research. Our research resoundingly affirmed with the scientific prevalence that our conclusions and their findings were harmonious. Endoscopic DCR offers superior relief of epiphora and results in no scar formation, which is more cosmetically acceptable and aesthetically pleasing. So it is our recommendation to consider endoscopic DCR as a primary choice of treatment for patients with nasolacrimal duct obstruction. These are the references we used in our study. Thank you.
Thank you, Asha, for the wonderful presentation. That was the last presentation by surgical session. Now, for the concluding comments, I request Professor Munir Imran to please come on stage for all the presentations. Thank you.
Came back after the tea break and join us again. And there were two state-of-the-art lectures in this session, and both were wonderful lectures to listen. One about the recent advances, and the other was about the demise of clinical acumen. ऊपर बड़ी लोगों ने नुकसान किया, उसको बड़ा बात हुई है. And then there were 5 research articles were presented by the students and the PG. I would like to thank all my coaches and our secretary group.
थोड़ा सा मैं चाहूँगा, एक तो स्टेट ऑफ आर्ट लेक्चर्स, एक डिवाइस क्लिनिक वैक्यूमन और दूसरा दोनों थोड़ा अपोजिट साइड पे, दूसरा एडवांसमेंट है, लेकिन दोनों अपनी जगह पे ज़रूरी हैं. मैं ऐड करता जाऊँ क्लिनिकल वैक्यूमन, बेटा ये बैठे हुए सारे ऊपर और ट्रेनी हैं. क्लिनिकल वैक्यूमन ऐसी चीज़ है, कुछ तो और लेकिन ये एक्वायर हो सकती है, ज़्यादा एक्वायर होती है, और उसके लिए बेहतरीन तरीका यही है कि आप पेशेंट के साथ इंटरेक्ट करें. ये बड़ा इंपॉर्टेंट है. जितने आप पेशेंट देखेंगे ये क्लिनिकल एक्यूमेंट डेवलप होती है, ये बड़ी ज़रूरी है. एक अच्छा क्लिनिशियन होने के लिए क्लिनिकल एक्यूमेंट बहुत ज़रूरी है. हमें खुशी हो कोई हमें कि ये बड़ा अच्छा क्लिनिशियन है, बड़ा अच्छा फिजिशियन है, या सिर्फ ये ज़रूरी नहीं है. मैं तो कई दफ़ा कहता हूँ सर्जरी के हवाले से कि सर्जन इज ए फिजिशियन हु कैन ऑपरेट. ट्रीट करते हैं, सिर्फ एक दिमाग को ब्रेक नहीं करते, ये इनसाइट होनी चाहिए. नंबर 2, रोबोटिक सर्जरी की बात हो रही थी, इससे फ्यूचर इसका बहुत है, और इसको मैं मुफ्तजात साहब जो कह रहे थे ये नहीं होना है. लेकिन एक बात याद रखें, इट्स नॉट रोबोटिक सर्जरी, इट इज रोबोटिक असिस्टेड सर्जरी. उसके पीछे अभी भी एक आदमी बैठा हुआ है जो उसको चला रहा है, और उसकी गलती रोबोट के खाते में नहीं जाएगी. उतना मरीज ने है तो स्टिल रोबोट के पीछे एक आदमी बैठा हुआ है, सर्जन बैठा हुआ है, उसकी अपनी वैल्यू है. तो ये बड़ी इट्स नॉट ओनली रोबोटिक सर्जरी, इट इज रोबोट असिस्टेड सर्जरी है. तो बाकी जो पेपर्स अच्छी ओरिजिनल रिसर्च थी बच्चों की, बहुत अच्छा लगा. अल्लाह करे और आगे बढ़े। पहला सिंपोजियम था, इंशाल्लाह विद टाइम वी विल इम्प्रूव एंड वी थैंक ऑल द ऑडियंस उनकी पेशेंस के चाय के बाद भी बाकी आ गए वापस, तो थोड़ी मेहनत करनी पड़ी है आने में। थैंक यू वेरी मच।
Thank you very much, sir. That concludes session on the surgery. Now I will request Department of Gynecology, Professor Dr. Raksha and her colleagues, please take on the stage for further proceedings.
Honorable Chairman, Co-Chairperson and Principal Akhtar Saeed Medical and Dental College, respected Professor, distinguished guests, and my dear students, Assalamu alaikum. I extend my warmest welcome to all of you as we all gather here today for this medical symposium under the inspiring theme of Health for All. And theme for this session of the symposium is Mother and Child, a theme very close to our heart. It is a theme that encapsulates our collective commitment to ensuring that health care is accessible to everyone, regardless of their background, location, or circumstances. Your presence here is a testament to your dedication to this noble cause. Let me highlight you today's program. This program will include 2 state-of-the-art guest speaker lectures, followed by 5 paper presentations. Before that, I would like to invite a panel of experts to be seated on the stage. The chairperson of this session of the symposium is Professor Dr. Fariha Farooq. Madam is co-chairperson of Akhtar Saeed Medical and Dental College, and she is the head of Department of Gynae Ops. She is being a fellow of College of Physician of Surgeons of Pakistan. She is certified laparoscopic and stereoscopic surgeon as well as IVF consultant. Madam is actively involved in research work. She has currently presented her research in FIGO and RCOG. We are honored to have her here. The remaining 3 co-chairs include, please welcome Professor Dr. Rashid Zia, Professor Yasir Amin, and Professor Nadeem. Thank you all. Let us embark on this journey together, where mother and child health is just not a slogan, but a true reality. Before we delve into further discussion, I would like to introduce a remarkable individual whose work aligns perfectly with our theme, Professor Dr. Rubina Suhail, a name that doesn't need any introduction, a name synonymous with transformative healthcare. She has made substantial contribution to our academic and medical community in the field of gynae ops. Madam is a fellow of College of Physician of Surgeon of Pakistan and fellow of Royal College of Gynae Ops. She is consultant obstetrician and gynecologist. She is champion of sexual and reproductive health. She is also chair of FIGO committee, and she has been past president of South Asian Federation of Gynae Ops. Her tireless efforts in advancing the cause of mother and child health has reshaped the landscape of women's health in Pakistan. Dr. Suhail words exemplified the idea that women health is just not an inclusive right, it's an inclusive right, not a privilege. We are honored to have her here. Please welcome Professor Dr. Rubina Suhail.
Bismillahirrahmanirrahim. I think it would be amiss if I don't thank Professor Priya Farooq, Professor Abha Shabir, and the organizing committee of this conference to invite me over here. It's a great privilege for me and it's an honor for me. So thank you very much for inviting me over here. And for the beautiful introduction that you gave me, I never knew Quebec was a school. So thank you very much. There's something very important what we have done for this seminar today. That is the theme, Health for All. I don't know, I see a lot of students sitting over here, but so I would like to mention over here that Health for All is basically Sustainable Development Goal 3. Sustainable Development Goals are important goals for us which are to do with health, with education, with poverty alleviation, so many things, gender equality, and that is why we are also a signatory to the Sustainable Development Goals. So that is why I think whoever chose this theme and probably was the principal, they chose a very good. So thank you very much for choosing this. Today I'm going to talk on a topic which I think is very important from the maternal health perspective. And all of us know, and Dr. Humain is going to come after me and he's going to give a talk on an important issue related to pediatrics. So I would just like to say that mother and child are linked together. So if a mother dies, the child has no future. And the child is left unattended, and actually the mortality rate of the child will also increase if there is no mother to take care of the child. That is why it is very important to save the mother. And it is a right of the mother to be saved. As I said, it is not a privilege, it is our right as females to be saved and to live, to take care of our families and our children. Today I am going to talk about the important topic of a modified PPH bundle initiative in Pakistan, which is a strategy to reduce maternal mortality. If you look at the situation of Pakistan, we have a maternal mortality rate of 186 per 100,000 live births. When I was junior, I would always think it is per 100,000 live births and it is only 186. So maybe it is not too much. So whatever the maternal mortality rate at that time was. But believe me, there are countries who have got maternal mortality in single digits. It is that important to save the life of a mother. And it is that important for all of us to get together. So what does the Sustainable Development Goal 3 say about the lives? It says that we have to ensure healthy lives and we have to promote the well-being for all ages in the new SDG agenda, and that is what we are trying to do, to reduce the maternal mortality, to make sure that by 2030 we have a maternal mortality reduced to 140. And again, when you look at the figures, you say 186 to 140, no big deal. But it is actually a big deal because it needs a considerate effort and it needs a coordinated approach to achieve the target for maternal mortality reduction. Now, there are different studies have been conducted which show us that there are 4 interventions to reduce maternal mortality. I won't go into the detail of those interventions, but just to say that contraceptive services, provision of safe abortion, managing non-communicable disease and preventing it, and prevention and management of PPH are the 4 strategies by which we could reduce maternal death. And today I am going to talk about one of those strategies, and that strategy is reducing maternal death by prevention and management of postpartum hemorrhage. So in Pakistan, obstetrical hemorrhage, especially postpartum hemorrhage, is the leading cause of maternal death, and uterine atony is actually one of the significant factors after delivery which leads to the death of the mothers. So the question is that when we talk like this, sometimes we forget that the government is also doing many things regarding reduction of maternal mortality. So I would first just like to share with you that what is the government doing actually to reduce maternal mortality, and especially the government of Punjab. So what they have done is that they have tried to institutionalize the deliveries. So the BHUs in Punjab have been converted into facilities, and 49% of BHUs, according to the official data, which is a little bit old, about 4 years old, were serving to serve as 24/7 centers. The number has since then increased somewhat. Provision of emergency obstetrical care, making sure that misoprostol and tranexamic acid are included in the essential drug list, and they are available in all healthcare facilities where delivery can take place. making sure to address the three delays. So the first delay is addressed by the provision of the lady health workers to the lady health worker program. The second delay, which is the delay in transport, is addressed by provision of rural ambulance, which is called 1034 service. As in Lahore, there is 2212, rural area में 1034 है. It is not uniformly as such available in all of the rural areas. The third delay is patient triage. Is supposed to try their patients and low risk. So a high risk patient has to be seen by the senior most consultant in the shortest possible time, which could be as less as 5 to 10 minutes, and senior registrars are also included in the consultants. Then the government is working on a referral system of them working on the health management information system and the MPDSR, which is the maternal and perinatal death surveillance reporting. So these are all the interventions that the government is doing. Now the we going regarding PPH and what is it that I am going to talk to you about. So basically currently for PPH management due to age only, there are two methods of management. One is called the PPH emergency care using PPH bundle approach, and the other is called e-model. Both of them are actually very much similar to each other, and they are basically based on the ideology that we have to do early detection of PPH and manage it as soon as possible. Now, I know that Dr. Faria Farooq has recently conducted a very good workshop on PPH bundle approach, and I'm sure that she'll talk to you about it. But basically, PPH bundle approach is two bundles, and I would like you to focus on it a little bit because clinical bundles we all know. But there are something very important which is called the non-clinical bundle. And I believe for one, that if we are able to follow the non-clinical bundles successfully, we will be able to save the life of women not only from PPH, but also from other conditions or other obstetrical emergencies like eclampsia, like other conditions, we will be able to do it. Now, what are the non-clinical bundles? I would like to talk about them first. They are basically leadership capacity development, ensuring that facility is ready 24/7 to provide emergency services, respectful maternity care to our women, being able to communicate effectively, and all of you who are students know that a very important part of your examination actually is to be able to communicate well with the patient and amongst your colleagues. So that is important. Then network integration, that means the referral services communication network that has to be really strong, and improvement quality. Pakistan did not achieve the Millennium Development Goals that it was supposed to achieve. Why did it not achieve the Millennium Development Goals? The reason was that although they had improved their antenatal care, but the quality of antenatal care was actually very poor. So quality is very important. So these 6 interventions of non-clinical bundle approach will help you go a long way if you focus on them. The clinical bundles are the first response and the refractory response bundles. First response includes the uterotonics, isotonic crystalloids, use of transdemic acid and uterine massage. And the refractory bundles are aortic compression, bimanual uterine compression, non-pneumatic anti-shock garment, which is not freely available in Pakistan, but which costs only $100 and it can save the life of your patient. And the intrauterine balloon tamponade. I will go and talk about them a little bit in detail later on. And this is e-model. Basically, it again talks about early detection of lesion and evaluation. So, काफी similar. Now, the point is that when you are trying to manage PPH, आप में से जितने लोग गायनी में काम करते हैं, मेरा उनसे एक सवाल है. How do you diagnose PPH? Can anybody answer it for me? I'm sure many of you can answer and you maybe feel shy not to answer. अगर ब्लड लॉस नॉर्मल डिलीवरी में 500 ml से ज़्यादा हो जाए तो we call it PPH. But my next question to you would be, how do you know it is 500 ml? The answer is you don't know. When you don't know it is 500 ml, then you depend on the pulse, on the blood pressure, on the cleanliness of the skin, and on a huge amount of blood loss to say that PPH has happened. So the modified PPH bundle approach that we are applying is that we are saying two things. First, let's talk about prevention of PPH. In that, what we are saying is manage third stage of labor by active management. The second thing we are saying is that every patient, so a lot of boys are also sitting over here, and my advice to all of you, especially when you're going to go and work in the BHU and RNC is कि जब आपके पास एंटीनेटल के लिए कोई मरीज आए, आपने एक काम इंश्योर करना है, ये मेरा मैसेज है आपके लिए, and that thing that you have to ensure is that you have to ensure that every woman who delivers should be at a hemoglobin of minimum 11 before her delivery. So हमने सर्विसेज हॉस्पिटल में क्या किया था कि हम 28 वीक्स में हर पेशेंट का हीमोग्लोबिन रीवैल्यूएट करते थे और जितना डेफिसिट होता था उसको हम कैलकुलेट करके उसको इंजेक्टेबल आयरन दे देते थे टू मेक श्योर दैट एवरी वुमन डिलीवर्स एट अ हीमोग्लोबिन ऑफ 11. इफ यू आर एबल टू डू दैट आपका पीपीएच का इंसिडेंस कम हो जाएगा. सो माय फर्स्ट एडवाइस इज प्रिवेंशन ऑफ पीपीएच. द सेकंड थिंग इज डायग्नोसिस ऑफ पीपीएच. एंड इफ यू लुक एट द लेफ्ट साइड, द राइट साइड ऑफ योर स्क्रीन, you are able to see a chart, and that chart should be pasted in every delivery room to show you how to calculate the assessment of blood loss. If you are able to calculate how much blood loss has happened during your delivery, then you will be able to diagnose PPH even before the clinical symptoms and signs of PPH arise. And that is my second message for today. Always assess blood loss at every delivery. जिस वक्त आपने 500 ml को क्रॉस कर लिया, that is the time to start the PPH bundle approach. But before you do that, declare PPH. When we were young and working in the labor room, जब PPH होता था और हम किसी को call for help करना चाहते थे, there was no mechanism because we were in the delivery room alone with the patient. No staff to help us and no doctor to help us. So we have to make sure that there is an emergency bell or a PPH code that we declare and say that we need help in the labor room. And all the significant people, which should be an obstetrical rapid response team, must reach the labor room or the theatre immediately to help with the management of PPH. And then is the fourth step, which is the actual management of PPH. But you will realize that management of PPH is उससे पहले 3 बड़े काम हैं. वो काम है prevention of PPH, diagnosis of PPH, declaring PPH, and then you are going to manage the PPH by the clinical and non-clinical bundles which I talked about. And I know I will run short of time, although I am not running short of time just as yet, but just to mention the correction of anemia to make sure that every woman delivers with a hemoglobin of not less than 11, making sure that the primary bundle approach starts, एक ही चीज़ है primary bundle approach में. जब भी मैं किसी को जाके बात करती हूँ about management of PPH, I know that the crowd would say, we already know the management of PPH, why are you talking about it? The only reason I am talking about it is to ensure to you that the 4 components of the primary bundle have to be done together. You don't give one treatment, then wait, don't give the second treatment, then wait, do it all together and you will achieve good results for the management of PPH. Similarly, if within half an hour you are not able to control the bleeding, go on to the refractory bundle approach and that will help you. This picture is very important for me, and the reason that it is important for me, the round circle, it shows the PPH emergency response in the center, and all those non-clinical bundles that I talked about are covering it from the periphery. So leadership, respect for maternity care, communication, integrated approach, all these things form a very significant part of the management of PPH. Your perspective and your facility should be ready. You should be able to communicate and you should have a respectable rapid response team. This is sitting in the USA and his name is Mr. Thomas Burke. He is a doctor. And we contacted them and we said that we want to do something about PPH bundle approach because these people are the pioneers of PPH bundle approach. So in Colombo, last year in September, exactly 1 year and 1 month previously, we had our first workshop for training of master trainers. After we had our first workshop, we named our project the Mehfooz Ma Initiative. So Mehfooz Ma हमने इसलिए रखा because we wanted a local name जो कि हमें सबको motivate कर सके. तो इस वक्त Mehfooz Ma के 2 components हैं. एक है management of PPH और दूसरा है eradication of anemia campaign for Pakistan. So we have already started working on PPH management, but we are yet to start on anemia management right in a unified manner. So this just shows you the process, how do we go about it and how do we go and conduct workshops. So इसका एक पहले theoretical module है जो कि हम online करवाते हैं और ऑनलाइन थ्योरेटिकल मॉड्यूल के बाद हम जो है हम करवाते हैं द क्लिनिकल मॉड्यूल्स एंड द नॉन क्लिनिकल मॉड्यूल्स विच इज़ अ 2-day ट्रेनिंग। उस 2-day ट्रेनिंग के बाद जो हमारे ट्रेनर्स हैं दे बिकम मास्टर ट्रेनर्स एंड देन दे कैन गो एंड कंडक्ट वर्कशॉप्स इन अदर हॉस्पिटल्स। दिस इज जस्ट a histogram of the pre and post test to show you what do we do. So in Indian education campaign की मैंने आपको बात बता दी है, just in couple of minutes I'll tell you what we have achieved this far, and this is important. I showed you only 6 facilitators when we started, and this is what we are now. और ये जो facilitators का pool है, this does not cover every facilitator actually. So we have got many more facilitators जिनको डालने का मेरे पास थोड़ा टाइम कम था, तो मैंने नहीं डाले, but inshallah when I come back to you again, I will show you what a group we have generated. Just to show you what we have done in 1 year and 1 month, we have conducted 6 master trainers workshops, and we have trained people mostly from hospitals in Lahore so that they can go to the district hospitals and to the rural health centers to teach them how to prevent and manage postpartum hemorrhage. We have gone to various cities, and these are the 1-day 58 bundle approach workshops that we have conducted in various cities. We have done trickle down trainings, 2-day trainings, जहाँ हमने ट्रेन किया उन्होंने अपनी ट्रेनिंग्स पर खुद करवाई, and we have made presentations at various conferences talking about how important it is to manage postpartum hemorrhage for reduction of maternal mortality. I have run through these slides very quickly, but evidence is in seeing what you see. So these are the workshops conducted in Gujranwala, in Gujarat, in Sialkot, in Sargodha, in Hafizabad, in Allama Iqbal Medical College Lahore, in Fatima Jinnah Medical University Lahore, in King Edward Medical University Lahore, in Shalimar Medical and Dental College Lahore, in Hamid Aziz Hospital Lahore, in University of Lahore. This is what we have done, and I removed many of the pictures because I thought the time will not allow. What have we achieved? We have done 22 workshops in 11 cities of Pakistan. 2 provinces have been covered, 155 master trainers, 545 skill-based trainings, 150 trainings by trickle down, and 3 conference presentations have been done so far in a year's time. This is one of the pictures of the workshops that we conducted in Hamid Aziz Hospital. We have monthly meetings to see what we have achieved and what we are going to do in the future. So just a couple of pictures because I thought they would be interesting for you to see what we are doing. And the last meeting that we had was during the FIGO conference with Thomas Burke and his team to see where we are going to go. And one important thing I want to tell you is हम हमेशा पैसों की तलाश में रहते हैं और हम support ढूंढ रहे होते हैं. So all this work actually has been done without any help from any developmental partner, without any NGO, without any government support. But we have 3 important pharmaceuticals who are supporting our work. They are Sami Pharmaceutical, Hilton Pharmaceutical and Abbott Pharmaceutical. So they support the workshops that we conduct, and I'm really grateful to them. So the future plan basically is that we are going to build up on our existing work, we will collect data and make sure that we publicize. My objective is that I want to show to the world that Pakistan can save their mothers without a lot of help from external factors. And I think my objective of coming here today as well is that I would request all of you to join our team to become partners and to carry this talk, because no one person, 2 person or 10 persons can do it. We need the whole obstetrical fraternity, and we need the students of Akhtar Said Medical College to join hands with us. When you become doctors and go to your rural health center and BHU, make sure that you are working to save the life of the mother. This is your primary responsibility, whatever curriculum you might have. So with this, I would just like to thank you and thank the whole team of facilitators that we have collected. And I would just like to end with this saying, and this is a very prominent guy. His name is Professor Mahmoud Fatala. He is from Egypt, and he was the president of our international society, which is FIGO. And he said it a long time ago that mothers are not dying because of diseases we cannot treat. They are dying because as a society we have to decide whether their lives are worth saving or not. So please save the life of the mothers. Thank you very much.
Thank you so much, madam, for the words of wisdom. Now I would like to request Professor Dr. Faria Farooq and Professor Nahid Jamal Farooqi to present sheet to Professor Dr. Rubina Suhail.
I thank Dr. Veena Suhail because she is my teacher and my mentor during my training for post-graduation. And I'm really, really indebted to her. Thank you, Dr. Veena.
Ladies and gentlemen, distinguished colleagues and esteemed participants, Assalamu alaikum. I am Dr. Nidasa from Pediatrics Department, and I feel privileged to introduce our second guest speaker for today, Professor Dr. Junaid Rashid, who is a prominent figure in the field of pediatrics medicine, my teacher and my mentor. Currently serving as the Pro-Vice Chancellor, Dean of Faculty of Medicine and Allied Specialties at University of Child Sciences and Children's Hospital, Lahore. With over 28 years of teaching and clinical experience, Professor Rashid's contribution to the medical community are immeasurable. His contributions to the medical education has helped to shape the careers of many young professionals and have played a pivotal role in advancing the field of pediatrics in Pakistan. Today, we have the privilege of hearing from Professor Junaid Rashid on a topic of immense importance, that is, the right nutrition advice for the right age, the missing link of the intergenerational cycle of malnutrition. This is the subject that goes to the heart of the well-being of our younger generation and holds the key to breaking the cycle of malnutrition that affects so many kids. So please join me in giving a warm welcome to Professor Junaid Rashid, a true luminary in the field of pediatrics, as he shares his knowledge and wisdom with us today.
Bismillahirrahmanirrahim. Allahumma salli ala sayyidina Muhammadin wa ala ali sayyidina Muhammad. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. First of all, I am really thankful to Professor Aga Shabir, my senior, my teacher, a very good pediatrician, a very renowned figure in pediatrics, to all the administration and the organizing committee of this conference for giving me this opportunity to spend some time with you people on a very important topic. Although in state-of-art lectures, generally the mode of talk is in English, but I would prefer to use the hybrid language because many a time when we talk of mother and child, we can simply replicate the sentences a mother uses when she's telling about her child. That is how we learn how to reply and how to sort out what the mother's problem is. यहाँ से करना होगा. This is my university and the University of Child Sciences. This is the building where I work. But first of all, let's start pediatric population in Pakistan. 45% of the population, that is out of 23 crore, it's around 11 crore people who are below the age of 18. We have around 18,984 births every day. As we are sitting here for the last 1 hour, 800 children have been born in Pakistan. 21% of those who are born in Pakistan are premature. IUGR, intrauterine growth retarded. And then you come to know when these people concentrate on a health system, a baby gives. Out of all children born, 19% are low birth rate and without being attended by somebody. And unfortunately, when he or she leaves his first breath, there is nobody to support around. And unfortunately, if at all, but can I have a patient listening, please? मेडिकल कॉलेज for 20 years, तो मुझे बच्चों के साथ थोड़ा की आदत है, इसलिए आप तवज्जो से सुन लीजिए. जी, न्यूनेटल इन्फेक्शंस, द हाईएस्ट कॉज ऑफ डेथ. या आप थोड़ा थोड़ा अपना लोड देखते जाइए आपके मुल्क के क्या मसाइल हैं पीडियाट्रिक के, बिकॉज यू आर द फ्यूचर गोइंग टू हैंडल इट. लैक ऑफ ब्रेस्ट फीडिंग, malnutrition, infection, antibiotic stewardship. Now everybody has got a control of counter any antibiotic. You know, giving one antibiotic to a child kills a lot of healthy bacteria in the gut.
If a child is given multiple antibiotics, the problem created by those antibiotics in the intestine can go ahead for around 6 to 7 months to come forward, and you will find a chain of infection coming in the child and saying कि डॉक्टर साहब ये पहले नहीं बीमार था, पिछले 3 महीनों में ये 4 दफा बीमार हो चुका है. तो injudicious use of antibiotics for smaller infection is causing a lot of problems, and that is leading to a lot of children coming to our hospital. Obviously, genetic problems. Children's Hospital did a research on 30,000 families of genetic mapping, whole genome sequencing, and a lot of genetic disorders, Gaucher's disease, Niemann-Pick disease were discovered in Pakistan. We have a 7% of thalassemia rate. 7% means micronutrient deficiency. Doctor, my son is micronutrient deficient. The iron is not adequate, the vitamin D is not adequate, the calcium is not adequate, the zinc is not adequate, the vitamin A is not adequate, and these all micronutrients, once they are not adequate, they influence the processes occurring in a child, especially in case of immunity. Clean water. We don't have a source of reach of clean water. Illiteracy. 3 करोड़ बच्चा पाकिस्तान में स्कूल नहीं जाता. It's a big population not going to school out of the 11 crore, and out of the 8 crore who go to school, many of them have got learning disabilities, many of them have got deafness, and they are unable to learn what they are trying to be learned. Processed food. This generation we are facing has 3 problems: polluted air, processed food, and screen time. हवा का तो हम शायद ज्यादा न कर सके, but we can control processed food and screen time. I'll tell you how we can do it. Obviously, screen time, screen dependency disorder. Anybody using the screen for more than 2 hours a day, and he or she is dependent for his essentials on the screen. इसके बगैर खाना नहीं खाता, इसके बगैर ये नहीं करता. We are responsible for putting a child to a screen at a very young age. एक छोटा सा बच्चा मेरे क्लिनिक पे आता है, जरा सा उल्टा माउस के आगे मोबाइल रखती है, and once the baby is getting ready for that, then we blame the baby that he or she is not leaving the screen. Then we come on to the polluted air. Obviously, right now we are having a smog time. I attended a conference in National Assembly back in 2019. Asthma statistics in Children's Hospital. There were 6,000 OPD visits in 2006. There turned to 11,000 OPD visits of asthma in 2015. So almost double the rise in asthma because of a lot of air problems. Child abuse and neglect. That's a big problem. Almost uncovered. Adolescent once again. Sedentary lifestyle. Low physical activity. Screen time. आप में से बहुत से स्टेज से गुजरी हैं, कुछ खुद भी अपने आप को अभी भी इसमें समझते होंगे. Definitely violence, substance abuse. मैं अपने स्कूल के बच्चे के प्रिंसिपल के पास गया, मैंने कहा कोई खिदमत मेरे लाइक आई कैन डू समथिंग है. She said, डॉक्टर साहब प्लीज कैन यू कम एंड से समथिंग अबाउट सब्सटेंस अब्यूज. ये जो छल्ली वाला बाहर छल्ली बेचता है, ये क्या कर रहा है? मेरे बच्चे बहुत सारे सीनियर्स look after 10-15 schools. It's a growing problem under the carpet. We have to look into it. We don't have any proper center to look into because of a population and a stigma है कि किसी के बच्चे का पता चल जाए substance abuse का. Mental health problem, aggression. You know, screen is causing aggression. Screen is causing delayed speech. हर दूसरे हफ्ते एक बच्चा 2 बच्चे आते हैं, डॉक्टर साहब ये बोलता नहीं. और उसकी दादी कहती है कि उसका अब्बू भी 4 साल में बोला था और वो अभी तक चुप नहीं हुआ. लेकिन the point is that we have to understand that screen time is causing a lot of problems. Then obesity. It was 2% in 1990 in adolescence, has gone to 9.5%. भला हो processed food का, भला हो junk food का. People come to me and say, डॉक्टर साहब ये पेप्सी बहुत पीता है. 4 साल का बच्चा. You know, one mother came to me back in 2003 saying कि मेरी जिठानी का बच्चा पेप्सी पीता है. मेरा नहीं पीता, मैं दिखाना चाहती हूँ मेंटली नॉर्मल है कि नहीं. Do you see, this has gone. If you buy in your grocery and you open a fridge and 2 Pepsis are lying right there, anybody will take it. You have to understand how to get rid of it. Now, this is the burden of triple burden. Triple burden means micronutrient deficiency, obesity at one side, malnutrition at other side. 40% of Pakistani population is short-stated. छोटे कद का बच्चा समझेंगे क्या नुकसान है. You would not be able to contribute for economy. If it is female, she'll be a short-statured mother, leading to more chance of cesarean section than a further short generation child. और ये साइकिल ऐसा घूमता है कि आप हैरान हो जाएंगे कि ये इंटरजेनरेशनल साइकिल. अंडरवेट बच्चे, wasted का वर्ड यूज होता है for those who are final year. Wasted means a child is not adequate for that given height. जितनी हड्डी है उसमें उतनी बोटी नहीं चढ़ी. A baby is of a height of 100 centimeters, which is 4 years, that needs a weighted weight of 16 kg. वो बच्चा 8 किलो का है, वो बच्चा 9 किलो का है. Stunted, wasted, underweight. Then we come across, this is the figure that you see, 40% stunted, 28%, 29% underweight, and 9.5% overweight, and it's there in rural as well as urban areas. Now, what is the intergenerational cycle of malnutrition? एक कमजोर बच्चा पैदा हो 2 kg का, the minimum weight should have been 2.5, इसके नीचे 100 ग्राम का 1 ग्राम भी हो तो लो बर्थ वेट कहलाएगा. 2 kg का बच्चा पैदा हुआ, he is a smaller child, grow up into a smaller adult. If he is a male, he will not be able to contribute enough, and if she is a female, that will be a small mother with a low growth, low weight, both adolescent and leading to a small sized mother, and the cycle goes on and on and on. This is known as intergenerational cycle of malnutrition. We have many other intergenerational cycles. We have intergenerational cycle of poverty. इसका बाप भी गरीब था, ये भी गरीब है, आगे भी गरीब. We have intergenerational cycle of cousin marriages. कि जी वो दादा परदादा से चलते 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 बहुत सी बीमारियां within the family constraint कर रही हैं. You have to understand that intervention is required at every stage. कि आपको जनरेशन में न्यूबॉर्न पे इंटरवीन करना है, एक प्रेग्नेंट माँ पे इंटरवीन करना है, उसको एक सेहतमंद माँ बनाने के लिए अडोलेसेंट फीमेल पे इंटरवीन करना है, उसको एक सेहतमंद अडोलेसेंट बनाने के लिए चाइल्डहुड पे इंटरवीन करना है. तो दिस साइकिल हैज अ लॉट ऑफ इंपॉर्टेंस इन आवर सर्कल. नाउ व्हाट एग्जैक्टली हैपेंस इफ अ बेबी इज लो बर्थ वेट? विल बी मोर हैविंग चांसेस ऑफ इन्फेक्शन. मैं आपको भी बताऊंगा कि प्री मैच्योर बच्चे का दिमाग कम न्यूरॉन्स रखता है एज कम्पेयर टू एन एडल्ट जो मैच्योर बच्चा हो. एक IUGR की कॉग्निशन कम होती है एज कम्पेयर टू अ फुल टर्म बेबी. तो भी आपके अस्पतालों पे, आपके हेल्थ सिस्टम पे एक बच्चा कैसे वेट गेन करता है? इंडिविजुअल फैक्टर, यही कुछ नहीं खाता, बात नहीं मानता, सुनता नहीं है, डाइटरी इंटेक है, प्रेफरेंसेस है, फिजिकल एक्टिविटी कोई नहीं है, बच्चे के अपने करेंगे. You know, a lot of feeders, 5 feeders a day, mashallah, my son is taking 6 feeders. Feeder as a tool is a source of giving too much of milk, which is not required. You need only 18% of your total calories at the age of 2 years from milk and all milk-based food. Only 18%. एक ऑस दूध में 20 कैलोरीज, एक 8 ऑस का फीडर 160 कैलोरीज, 5 फीडर का मतलब 900 कैलोरी फीडर से लेगा. क्या खाएगा? डॉक्टर साहब की रात में पीता है, एक 10 बजे पी के सोता है, फिर 1 बजे एक आवाज आती है तो अगला फीडर, 5 बजे अगली आवाज आती है तो अगला फीडर, सुबह 8 बजे अगली आती है तो अगला फीडर. द प्रॉब्लम गोज ऑन एंड ऑन एंड ऑन, एंड दैट लीड्स टू अ लॉट ऑफ पिकी ईटिंग. इफ यू टेक टू मच ऑफ बॉटल फीड, यू हैव माइक्रोन्यूट्रिएंट डेफिशिएंसी. गाय के दूध में आयरन बहुत कम होता है. तमाम बच्चे हुआ टेकिंग फ्रेश मिल्क नॉट विल कम अप टू अस. आप मेरे वार्ड में आइए, 80% बच्चे जो है बकरी डब्बा, एंड दे आर ऑल आयरन डेफिशिएंट बिकॉज ऑफ टेकिंग टू मच ऑफ मिल्क. डॉक्टर साहब इसके बगैर सोता नहीं, आदत हमने डाली, वो खुद खरीद के नहीं लाया. तो वी हैव टू अंडरस्टैंड कि हमने कितनी छोटी छोटी इंटरवेंशन से कितना टाइमली हम प्रोसीड कर सकते हैं. Then this is a family factor. TV watching है, पेरेंट्स की अपनी बात है. Then we come on to the community, जहाँ पे आप रहते हैं वहाँ का क्या इफेक्ट है. तो एक बच्चे के वेट में उसकी अपनी घर का, उसकी अपनी जात का, उसकी फैमिली का, उसके प्रेफरेंसेस का. You know, we have a very less vegetable intake in Pakistan. Just when you cook something of veggies, if you cook something of shalgam or something like that, भाई इस बच्चे को अंडा पराठा बना. The way you cook anything vegetable, इसके लिए आप कोई nuggets निकाल लीजिए, इसके लिए कुछ और निकाल लीजिए. We are not understanding that your neighbor country is growing up. जो आपको 8-10 बदमाश थे जो फिल्मों में दिखाते हैं, सब सब्जियां खा के बदमाश बने. So why can't we be? If you don't take enough fiber, if you don't take enough micronutrients, you have to take fruits and vegetables as a balance of your intestine to keep a sound balance in your gut. The gut-brain axis, the gut microbiome that needs fruits and vegetables. And you have to have a lot of percentage of that. First 1000 days of life, बच्चों आप लोगों के लिए जिंदगी के पहले 1000 दिन, माँ के पेट में बच्चा शुरू होने से दूसरी सालगिरह का केक काटने तक पहले 1000 दिन. 217 pregnancy and 730 beyond. तो वो लाइक आपको अंडरस्टैंड करना है कि उसमें क्या क्या इन्फ्लुएंसेस होते हैं जिससे बच्चे का, एंड द बेबी इज डन इन द फर्स्ट 1000 days. Your brain, you know, the brain doubles in volume in the first year of life. It will never happen again. The brain 80% is done by 3 years of age. आप और हम जो बैठे हैं 80% दिमाग हमारा 3 साल से बन चुका था, तभी हमारी बहुत सी हरकतें 3 साल वाली की हैं. Anyway, maternal nutrition. You need, I think there are champions of maternal nutrition sitting in front of me, तो मैं इसमें बहुत मुख्तसर बात करूँगा because that is part of my presentation, that's why I'm talking about it. 300 कैलोरी फालतू per day. Now you see pregnancy and brain development. A child has got, या आप लोग जो ताज़ा एम्ब्रियोलॉजी पढ़ के आए हैं, they must be knowing it, that you will do by 16 days, 4 हफ्ते पे 10,000 सेल, 24 हफ्ते पे 10 मिलियन सेल, 7 महीने के बच्चे का ब्रेन जो है वो करीबन अडल्ट ब्रेन के करीब बना होता है. Now the nutrients which are required for growth, you have to focus on folate, you have to focus on zinc. आपको by as a pediatrician, as a healthcare provider, as a gynecologist, as a physician, आपको पता होना चाहिए कौन सी खुराक में कौन सी चीज ज्यादा दस्तयाब है. उसके फूड एक्सचेंज पता होना चाहिए. अगर एक माँ कहती मैं गोश्त अफोर्ड नहीं करती, मुझे जिंक खाना है, तो आपको पता होना चाहिए मुतबादल क्या है. Unless you give this alternate, तो जो आपको मदर्स में न्यूट्रिशन में करना है, that is you have to look into vitamin C, iodine, folic acid, calcium, vitamin A and iron. And that's very important in a feeding mother. You know, एक माँ जब बच्चे को दूध पिलाती है, 9 महीने का हमल, 24 महीने का दूध, एक लड़की 33 महीने अपनी जान इस्तेमाल करती है एक बच्चा मैनेज करने के लिए. 2 चिल्ड्रन जिसको माँ अपना दूध पिलाए 66 महीने, 3 बच्चों को पिलाए 99 महीने, मीन्स 8.5 years in the first 10 years of our marriage, जो उसका टिपिकल मैरिटल एज होती है, कि आप कहते हैं कि अर्ली मैरिटल लाइफ से पहले 10 साल जिसमें फैमिली कंप्लीट करती है, उसमें 8.5 साल या वो हामिला है या वो दूध पिला रही है. यू हैव टू लुक आफ्टर द मदर्स हेल्थ. जब माएँ प्रेगनेंसी में होती है तो बहुत सी वाइटामिन लेती है. द मोमेंट दे कम टू मदर फीडिंग, दे ड्रॉप द लिस्ट ऑफ टेकिंग वाइटामिन. वी हैव टू इंटरफेयर विद दैट. यू नीड अ लॉट ऑफ कैल्शियम, यू नीड अ लॉट ऑफ आयरन, यू नीड अ लॉट ऑफ vitamins during your feeding so that you're always adequate. And if at all another pregnancy starts during feeding, the mother is not good enough. So that has to be a full-fledged cycle. Every feeding mother should be looked after regarding food and nutrition. Now, this is a premature baby. Immature neurobiological system. आप अपना बच्चा नर्सरी में दाखिल करते हैं ना 1.5 kg का, आपका ख्याल है हमने दाखिल किया, उसकी इन्फेक्शन कंट्रोल की, घर भेज दिया. ही और शी इज फेसिंग अ लॉट ऑफ स्ट्रेस, प्रिकिंग, सैम्पलिंग, एनजी, कैथेटर, ऑक्सीजन, वेंटिलेटर. दैट स्ट्रेस कैन इवन टोटली परमानेंटली डिस्टर्ब द न्यूरोएंडोक्राइन, ऑटोनॉमिक एंड कार्डियोवास्कुलर सिस्टम रिस्पॉन्सेस ऑफ दैट बेबी फॉर लाइफ इवन. सो दैट्स नॉट अ इजी टास्क. एक प्रीमेच्योर बच्चा हो जाए पर हम समझे कि इसको कुछ नहीं हुआ, बाद में बड़ा होकर ठीक हो जाएगा. Infant nutrition. Now this is one of the most important point. Unfortunately, breastfeeding जो अल्लाह ताला का हुक्म है, बेटे आप सबको पता होगा, कुरान में लिखा. आप में से बहुत को ये भी पता होगा कि हज़रत मूसा अपनी वालिदा से कैसे मिले, कि कोई औरत ऐसी नहीं थी जो उनको नर्स कर सके, किसी को वो पकड़ नहीं रहे थे और अपनी वालिदा को पकड़ा और फिर फाइनली वहां से. That is another lesson of mother feeding. This is a newborn brain. आप देखो, जो न्यूबॉर्न पैदा होता है अपने तमाम न्यूरॉन्स लेके पैदा होता है, जो उसने सारी जिंदगी इस्तेमाल करने. मैं अपनी 5 उंगलियां हम सब लोग लेके पैदा होते हैं, बाद में बड़े होते तो नहीं होती, इसमें शामिल नहीं, एक्सेप्ट उस उंगली पे जो हम लोगों को उठाते हैं. नहीं, न्यूबॉर्न उसके आप सिनेप्सिस देखते, when you see the synapses at 1 month, see it at 9 months, a 2 years old brain has got double the synapses of an adult brain. मिलियंस ऑफ कनेक्शंस होते हैं एक सेकंड के अंदर, एक 2 साल के बच्चे के अंदर जब वो लर्निंग प्रोसेस स्टार्ट करता है. तो हाउ इंपॉर्टेंट इट इज कि प्रेगनेंसी में ब्रेन को कैसे लुक आफ्टर किया जाए और बाद में कैसे लुक आफ्टर किया जाए. अब इस सिनेप्सिस को रैपिडली बनाने के लिए यू नीड बेस्ट मिल्क. पॉलीअनसैचुरेटेड फैट आपको गाय भैंस में इस तरह नहीं मिलेगा. डब्बों में आपको इक्का दुक्का में केमिकल की शक्ल में मिलेगा. आपको जो कोलिन चाहिए, ओमेगा 3, ओमेगा 6 लोग क्लेम करते हैं दूधों में डालते हैं, सिर्फ केमिकल. जो नेचुरल आपको चाहिए, टॉनिन, कोलिन, इट्स ऑल अवेलेबल इन मदर्स मिल्क. प्लीज promote and fascinate your mothers कि तुम्हारा बच्चा, बहुत सारी माओं को शक होता है कि बाप पे न चला जाए, उनको कहें कि 10% ज़्यादा कहीं हो जाएगा माँ का दूध पीकर, तो काफ़ी इम्कान है कि बाप पे शायद नहीं जाएगा। 5 to 10% एक्स्ट्रा IQ है उस बच्चे का जो मदर फीड लेता है। इट्स लाइक इफ यू हैव अ हायर स्कोर, so that is a passion for the mother to be told. Gut microbiome, you give probiotics to your baby, इसको डायरिया हो गया, इसको फलां साशे दे दो, इसको फलां एम्प्यूल दे दो। A mother milk produces 200 species of germs. A mother milk produces lactobacillus, bifidobacterium. अगर आप माँ का दूध पिलाएंगे तो उस बच्चे को प्रोबायोटिक की जरूरत नहीं पिलाएंगे तो प्रोटियोबैक्टीरिया का बैलेंस, जो आपको गट बैक्टीरिया के बैलेंस की बात कर रहा हूँ, सब्जेक्ट को पढ़िए जाके, गट माइक्रोबायोम कितना रोल है इसका न्यूट्रिशन का इसके अंदर, तो उसका बैलेंस ऐसा डिस्टर्ब होगा कि वो बच्चा कभी भी अच्छी तरह ग्रो नहीं कर पाएगा। जो सैम चिल्ड्रन, जिसको हम स्वेट एक्यूट मैलन्यूट्रिशन बच्चे कहते हैं, उन सब के बैलेंस डिस्टर्ब होते हैं इंटेस्टाइन के बिकॉज ऑफ कम वजन, इन्फेक्शन, एंटीबायोटिक। माँ का दूध, काउस milk is not recommended. It has too much sodium for a human kidney below 1 year of age to tolerate. It does not have vitamin A or C. It does not have antibodies. It does not have human milk oligosaccharides. इतनी चीजें काम है, अल्लाह का हुक्म ऐसे नहीं आया। अब a mother comes to you, बेटे ये very important काउंसलिंग है, आपको माँ से कहेगी डॉक्टर साहब I want to give, मैं नहीं दे पा रही, मैं पिला नहीं पा रही। उसकी क्या वजह? The moment a baby is born with a small size. कुछ मैंने लिटरेचर पढ़ा, कहीं लिखा था बच्चे की टमी का साइज 14 ml है, कहीं लिखा था 20 ml है, कहीं लिखा था 5 ml। मैं 5 ml पे क्यों कन्विंस हुआ कि अल्लाह ताला ने पहले 5 दिनों में जो कोलोस्ट्रम आपको देना है, जो माँ को दिया है, वो 5-6 ml है। It's inappropriate for nature to have a larger tummy size in the baby with a lesser production of the mother, which are not coherent to each other. So it has to be कि अगर आप माँ और बच्चे को पहले 20-25 दिन गुत्था होने छोड़ दें, when you put a longer nipple, बच्चा माँ बेचारी सिजेरियन के बाद होश में आती है तो उसको खबर मिलती है कि हमने इसको 2-3 दफा एक आंस पिला दी। Stomach is an elastic body. It increases in size. The increase in size of the tummy increases the demand of the baby. उससे उसकी चीखों पुकार में इजाफा होता है। रो बहुत रहा है, चुप नहीं कर रहा, you put another feeder inside. Mother is producing 4-5 ml. The feeder is giving 30 ml. How can you match? This is known as nipple confusion. The mother's body is not ready on day one. You have to latch the mother constantly for 10-15 days so that there is a coherence and then they are capable of attaching to each other. अब उसमें जो नानी दादी का इंटरफेरेंस है, ये रो बहुत रहा है, ये चुप नहीं कर रहा, प्लीज ट्राई टू अंडरस्टैंड। रोना बच्चे की गुफ्तगू है, वो आपको अम्मी कहकर नहीं बुला सकता, हाथ खड़ा करके नहीं बुला सकता, बेल नहीं बजा सकता। He has to cry. You have to understand. If you put the baby to the mother, अब क्यों फीडर पिलाने से दूध नहीं आता? Unless you suck the mother, the brain is not stimulated. If the brain is not stimulated, there is no prolactin and oxytocin. किसी दवाई से हाइलेक्टा देने से दूध आर्टिफिशियली नहीं आएगा, because it has to be the order placed by the baby. आप ऑर्डर के बगैर कैसा घर में दूध नहीं आता? You have to place an order. जितना बच्चा माँ को सक करेगा उतना ब्रेन स्टिमुलेट होगा, साइकिल घूमता जाएगा, दूध बनता जाएगा। डॉक्टर साहब, the milk is not enough. A baby at 3 months of age will be doubling the weight. जिसने अपना वेट 3 महीने में डबल करना हो वो बार बार मांगेगा, बार बार बनेगा। डोंट गेट क्रेजी। अल्लाह ताला का हुक्म है, निकाम ना मुकम्मल नहीं छोड़ा गया, एक्सेप्ट है, ठीक है। तो अनलेस यू कीप ऑन द बेबी ऑन द मदर, फिर क्या है, ब्रेस्ट पंप लिख दो, वो 25-30 हज़ार की आइटम है, उससे दूध निकाल के 1 सेकेंड फीडर में डाल के देना। उसी लॉन्गर निपल से हमने बच्चे को दूध रखना है, वो रखेंगे बच्चा माँ का दूध पिएगा। आई नो इट्स डिफिकल्ट, यू हैव टू अंडरस्टैंड द कॉन्सेप्ट ऑफ 4 मिल्क एंड 5 मिल्क। अगर आप फीडर पिलाते हैं तो इट हैज गॉट अ यूनिफॉर्म फॉर्मूला, आप बच्चे को हिला लें फीडर को। मदर हैज गॉट अ 4 मिल्क विच इज मोर वाटर, जिससे प्यास ज्यादा बुझती है, भूख कम मिटती है। तो यू हैव टू अंडरस्टैंड दैट माँ को अगर आप 4-5 मिनट का टाइम, माँ दूध पिलाती है, बच्चा सो जाता है, उसको सुला देती है, दोबारा उसके रोना शुरू होता है, तो कहती पेट नहीं भरता। क्यों? शी हैज ओनली गिवन 4 मिनट। तो 15-20 मिनट की फीड पिलाना बच्चे को कॉन्स्टेंट स्टिमुलेट करके, उसकी नींद का इतना एहतराम होता है, हर 3 मिनट बाद सुला देते हैं, उसको लगा देते हैं। दिस इज नॉट द वे। So this is a strong message कि मदर्स फीडिंग को Unfortunately, we've been trying hard कि हम 6 महीने की maternity माओं के लिए डॉक्टर वीना गोयल यहाँ बैठी हैं, हम भी पार्ट ऑफ द टीम जहाँ हम जाके वो ब्रेस्ट फीडिंग रूल की बात भी करते हैं कि हर माँ को 6 महीने मिलने चाहिए तो वो एक्सक्लूसिव ब्रेस्ट फीडिंग कर सके, स्पेशली जो वर्किंग लड़कियाँ उनके लिए। Yet to do it, if Allah Ta'ala हमारी मदद करे। Then you come on to Khorak. Now there is a word known as food diversity. There is a word known as minimal acceptable diet. Minimal acceptable diet का मतलब होता है कि जितना फूड उसको चाहिए कितनी दफा और कितना डाइवर्स। तो देयर आर 6 ग्रुप्स ऑफ फूड। ग्रेन्स, वेजिटेबल्स में आलू इज नॉट अ वेजिटेबल प्लीज। जब मैं कहता हूँ फल खिलाओ तो केला, सब्जी खिलाओ तो आलू। कलर्ड वेजिटेबल्स, ग्रीन वेजिटेबल एंड लीफी वेजिटेबल्स, फ्रूट्स। Then you come on to proteins, animal and plant. Then you come on to milk and milk-based items. A desi ghee and a butter and a cheese and a yogurt, everything is milk. It's not only a feeder. Then come on to fat. And this is the sequence. Now this is the food plan of a 2-year-old child. You just see, if you imagine a pizza in a circle, how much amount of calories do you need from milk and milk-based items? It's hardly 1/8 of a pizza. And this is dominating right now. We are giving too much of milk. If you see the food pyramid, 65% of your calories are grains, vegetables and fruits. No added sugar, no added salt in the first year of life. Na kheer मीठी होगी, ना खिचड़ी नमकीन होगी, ठीक? Then when to introduce meat, 8 months of age, बच्चा 8 महीने का हो जाए, आप मिक्स्ड मीट उसमें इंट्रोड्यूस कर सकते हैं। रिस्पॉन्सिव केयर में क्या होता है? If a child can select his or her chocolate in a market, वो खुद जाके पसंद करता है ना, 2 महीने का 2 साल का बच्चा कहता है वो वाली टॉफी लेनी है, आप उसको जब वेजिटेबल खरीदने जाते हैं साथ लेके जाए। दी ऑरा ऑफ भिंडी या लेडी फिंगर, दी ऑरा ऑफ पोटैटो, दी ऑरा ऑफ पीस, वो उसको जैसे जैसे फेमिलियरिटी करेगा। फन इन द किचन हम कहते हैं, माँ के साथ किचन में रहना, ही विल बी मोर एक्सेप्टिंग इट। तो रेसिप्रोकल में द फैमिली हैज टू कंट्रीब्यूट। नाउ I've talked of micronutrient deficiencies. Yes, food refusal, लेता नहीं, मानता नहीं। The late you introduce, the more he will refuse. 6 महीने से साल के दरमियान जो बच्चा हमल में माँ ने वैरायटी ऑफ फूड खाया, उसकी एमनियोटिक फ्लूइड में जायके रिफ्लेक्ट हो। माँ ने दूध पिलाया, बहुत से जायके खाए, उसके मिल्क में जायके रिफ्लेक्ट होते हैं। When the baby starts taking a lot of food at 6 months to 1 year of age, the aura is familiar. मैंने आपको पहले भी कहीं देखा। So if you give a formula, monotone, एक जायका, then you come on to a market cereal, एक जायका। तो अब सब फलां सीरियल के ना, मैं नाम नहीं लेता, इट्स कॉमन प्लेस, आप सबको पता है कि सीरियल की बात कर रहा हूँ। अगर एक बच्चा नहीं खाता, चेंज द प्रेजेंटेशन, शक्ल बदलो। हम KFC के बर्गर में बंद गोभी का पत्ता खा जाते हैं, वैसे नहीं खाता, ठीक है? अगर वो नहीं खाता, एनवायरमेंट बदलो, फैमिली मिल के खाए, बंदा बदलो। माँ से बच्चे तंग आते हुए कई दफा होते हैं, आप दादी नानी सबको इन्वॉल्व कीजिए, फूड प्रेफरेंसेस को इंक्लूड कीजिए, बच्चे को किचन में इन्वॉल्व कीजिए, ग्रॉसरी में इन्वॉल्व कीजिए, एंड देन यू विल फाइंड डिफरेंट रिस्पॉन्स। लास्ट 1-2 स्लाइडें रह गई हैं, ये आप लोगों के मुताबिक बात है। 50% adolescents, 20% हाइट। पहले 2 साल 3 साल थे, दूसरी विंडो ऑफ अपॉर्चुनिटी एडोलेसेंट बच्चे बच्चियों जिनमें इंक्रीज ब्लड वॉल्यूम हो गया, जिसमें हार्मोनल चेंजेस आ गए हैं, जिसमें टीनेज प्रेगनेंसी का खतरा है, ये तमाम चीज़ों को लुक इनटू नहीं करेंगे। तो ये चार्ट मैं आपको दिखाऊंगा, ये डाइटरी प्लान्स हैं कि आपको कितने सर्विंग्स किस चीज़ की होनी चाहिए। आप लोग सब जाइए, पाकिस्तान डाइटरी गाइडलाइंस 2018 का पूरा PDF है 160 सफ़े का, उसमें तमाम डाइट प्लान्स ऑफ ऑल एजेस अवेलेबल हैं। That should be a mandatory module to be taught in every medical college, ideally कि आपको पता हो, because बेटे you are what you eat, and to eat is a necessity, but to eat intelligently is an art. Thank you very much.
Professor Rashid Zia and Professor Maliha Aslam to kindly come on the stage and present their sheet. Sir, Professor Aga Shabir, please come on the stage.
Now we will proceed to the next event of this session, which is paper presentation. I would like to introduce about the judges of this event. The judges of this event are Professor Atka Masood, Professor Ashish Siraj, Dr. Suhail Aslam, and Dr. Shaila Tabassu. Now proceeding on to paper presentation. First paper will be presented by Dr. Rida Fatma. She is postgraduate resident in Gynae Obs, and she will talk about obstetrical and fetal outcome in patients with abnormal CTG. Please welcome Dr. Rida Fatma. There is some delay with Dr. Rida presentation, so we will first listen to the presentation of Dr. Zanmina Hazar. She is again a postgraduate resident from Department of Gynae Obs, and she will talk about fetal-maternal outcomes of teenage versus adult pregnancy. Dr. Zanmina Hazar.
Assalamualaikum everyone. I am Dr. Zanmina Hazar, PGR Gynae Obs in Farooq Hospital. Today I am going to present the topic of fetal-maternal outcome of teenage versus adult pregnancy. The teenage pregnancy is a serious health problem worldwide. It is associated with adverse maternal and perinatal outcomes. According to WHO organization, teenage or adolescent pregnancy is a pregnancy occurring in girls aged between 10 to 19 years. In general, the teenage pregnancy is believed to be associated with a high risk of maternal complications and poor neonatal outcomes. Various international and local studies have concluded poor fetal-maternal outcome in teenage pregnancy. The literature showed that teenage pregnancy is a high-risk pregnancy due to its possible physical, psychological, socio-economic, and increased obstetric risk associated with teenagers. Less work has been done in this regard, and also conflicting data has been obtained from the literature. The aim of my study is to determine the association of adverse obstetrical and neonatal outcomes with teenage versus adult pregnancies and compare our local population results to the other local and international studies. This is a cross-sectional study design, and by using WHO calculator, a sample size of 124 females was calculated. 62 females in each group. A non-probability consecutive sampling technique was used. This study was conducted in the Department of Obstetrics and Gynecology, Farooq Hospital, Westwood branch, from 1st March 2022 to 31st of August 2022. Material and method. After the approval from Hospital Ethical Committee, females fulfilling the inclusion criteria were enrolled and divided into two groups. Group 1, pregnant women between 16 to 19 years of age. Group 2, pregnant women between 20 to 40 years of age. Obstetric and neonatal outcomes like anemia, preterm delivery, postpartum hemorrhage, low birth weight, and poor adverse scores were compared in the both cases. The inclusion criteria had females presenting at a gestational age of more than 28 weeks, with a parity less than 5. The excluding criteria were women with a history of medication intake like corticosteroids, anti-epileptics, and other drugs which may affect the pregnancy outcome. Women with pre-existing or current medical disorders such as diabetes mellitus, hypertension, renal disease, or cardiac disease or asthma were also excluded from the study. The both of the groups were followed throughout the pregnancy, and hemoglobin level at gestational age of delivery, mode of delivery, postpartum hemorrhage, these were noted in the both groups. The neonatal outcomes including birth weight and adverse score were also noted in the both groups. This all information was saved in a pre-designed pro forma. This data was then entered in the SPSS volume 26 for the analysis. Mean and standard deviation were calculated for quantitative variables, whereas qualitative variables, mode of delivery, adverse outcomes, anemia, preterm delivery, low birth weight, poor adverse score were analyzed by chi-square test. A p-value of 0.05 was taken as significant. Now coming to the results of our study. The demographics in both groups were a mean age of 17.53 was observed in group 1, a BMI of 28.6, and a gestational age of 31.1 in group 1 patients. Whereas the group 2 mothers had a mean age of 26.5, a BMI of 30.45, and a gestational age of 31.45. The distribution of parity in both groups were as group 1 had para 0 to 1 mothers 87%, while group 2 had 66% of para 0 to 1 mothers, while parity higher than 1 was observed 12% in group 1 mothers and 33% in group 2 mothers. Now comparing the obstetrical complications in both groups, the anemia was observed in 51.6% patients of group 1, while only in 14% patients of group 2. This had a p-value of 0.00, which was statistically significant. The rate of preterm delivery was observed 69.3% in group 1 patients, while 29% in group 2 patients with a p-value of 0.00, which was also statistically significant. The postpartum hemorrhage was observed in 6.4 mothers of group 1 and 3.2% in group 2 mothers with a p-value of 0.34. This was not found statistically significant. The neonatal complications were low birth weight and poor adverse. The low birth weight was noted in the mothers of 61.2% neonates in the mothers of group 1, while only 24.1% of group 2 mothers had low birth weight. While the poor adverse, 8% neonates in group 1 had poor adverse score, and 6.4% in group 2 had poor adverse score with a p-value of 0.5, which was not statistically significant. Coming to the mode of delivery in the both groups. The darker bar shows the STD rate, while the lighter color bar shows the low segment cesarean section. As we can see in group 1 patient, only 30% had STD, while 69.3% have low segment cesarean section. But the ratio was reversed in group 2 patient. In group 2 patient, 59.6% patients underwent STD, while 40.3% had low segment cesarean section. So to conclude, in our study we found a strong association of adverse obstetrical and neonatal outcomes in teenage pregnancies as compared with adult pregnancies. These results were found to be consistent with local and international studies in various setups in last few years. These are some of the latest references for the given data. Thank you so much.
Thank you, Dr. Zarmeena. Our next presenter is from Department of Gynae, Dr. Rida Fatma. She is going to talk about obstetrical and fetal outcome in patients with abnormal CTG. Dr. Rida Fatma.
Hospital. The study is obstetrical and fetal outcomes in patients with abnormal cardiotopography. This study was done by Dr. Nosheen Salahuddin, Professor Dr. Amreen Mukhtar, and Dr. Uzra Sahib. The purpose of the study was, the aim of this study was to evaluate the effect of abnormal CTG pattern in late antenatal period and labor on the obstetrical and neonatal outcomes in terms of mode of delivery and Apgar score of baby. Electronic fetal monitoring, cardiotopography provides information about the fetal condition. A normal trace indicates a well-oxygenated fetus, but an abnormal trace indicates compromised fetus. CTG is used as a screening tool to assess fetal well-being and to identify the possibility of asphyxia. Normal or reactive fetal heart rate pattern is characterized by a baseline heart rate between 110 to 160 beats per minute, a normal heart rate variability between 5 to 25 beats per minute, presence of periodic accelerations, and absence of deceleration. If one or more of its parameters are abnormal, it is regarded as non-reactive phase. According to NICE guidelines, the CTG pattern is divided in three categories: normal, suspicious, and pathological. Accurate interpretation of CTG is essential, and it is important to recognize the features that shows pathological CTG labor. That may imply possible hypoxia and birth asphyxia. Antepartum and intrapartum fetal testing and fetal monitoring help to detect fetal distress. Appropriate timely action based on these observations may help to prevent birth asphyxia. Methodology. This was a cross-sectional study conducted from January 2019 to December 2019 in Obstetrical and Gynecology Department of Akhtar Said Trust Teaching Hospital, Lahore, which is a teaching hospital affiliated with Akhtar Said Medical and Dental College. In this study, 214 high-risk patients were included who fulfill the inclusion criteria, which is gestational age of 37 to 42 weeks, capillary presentation with any high-risk factor, pre-labor rupture of membrane, increased fetal movements, antepartum hemorrhage, hypertensive disorder of pregnancy, gestational diabetes mellitus, post-late pregnancy, and bad obstetrical history. Exclusion criteria: women with multiple gestation, anomalous fetus, and admitted for elective cesarean section. Verbal consent was taken from patients and included in the study. According to the CTG findings, patients were divided into Group A, patients with reactive phase, and Group B with non-reactive phase. Mode of delivery was dependent upon stage of labor. In case of pathological pattern, prompt action was taken regarding mode of delivery. The newborns were evaluated in terms of Apgar score at 1 minute and at 5 minutes. Babies need resuscitation and need of neonatal intensive care unit admissions were also noted. Confidentiality of all the data was maintained. Statistical analysis. Data was analyzed by SPSS version 25. Qualitative data was presented in the form of frequency and percentage. Mean standard deviation was used for qualitative data like age and parity. Chi-square test was used for statistical analysis. P-value of less than 0.05 was considered as significant. Results. Group A included 124 patients with normal or reactive CTG, whereas Group B included 90 patients having abnormal or non-reactive CTG, including both suspicions and pathological. Among the patients, Group B, 22% of CTG were done in antenatal and 78 were done during labor. 76% shows pathological trace and 24% will show pathological trace and 76 in suspicious. Demographic data in study patients. The age between 26 to 30 years was 30.7% in Group A and 33.3% in Group B. Obstetrical outcome in study patients. 67.7% of Group A patients were multilateral and 66.7% in Group B were multilateral. 32.3% were trilateral in Group A and 33.3% in Group B. The mode of delivery. 53.2% in Group A were delivered by normal vaginal delivery and 13.3% in Group B. 4.8% were delivered by instrumental delivery in Group A and 10% in Group B. Whereas the rate of cesarean section was high in both groups, which was 42% in Group A and 76.7% in Group B. APGAR scored at 1 in 5 minutes in both units. The APGAR score at 1 minute was less than 79.7% of Group A and 18.9% in Group B. And it was greater than 7 in 62.1% in Group A and 34.4% in Group B. Neonatal outcome. Resuscitation was needed in 7.3% of Group A and 15.6% of Group B units. Admissions to neonatal ICU, early neonatal death rate was greater in Group B than units born to Group A. Early neonatal death was 4.1% in Group A and 13.9% in Group B. And stillbirth rate was 2.4 in Group A and 4.4 in Group B. Conclusion: cardiotocography can be used as a good screening tool for fetal surveillance, especially in centers where fetal blood sampling or fetal ECG is not available. Abnormal CTG may influence the maternal and fetal outcome and is associated with increased cesarean infection rate, which is also shown in our study when abnormal CTG pattern occurs and an urgent medical aid is called and preparation is made with pediatric. These are the references. Thank you so much.
Thank you, Dr. Veda. As we move forward to our next highlight of three-paper presentation, I am honored to call Dr. Hina Gawar, Associate President of Pediatrics Department, to illuminate us on the vast subject of the magnitude of hepatitis C virus infection among asymptomatic Pakistani children.
Assalamualaikum, I'm Dr. Hira Gawar, PGR Pediatrics, Upstate Trust Hospital. The topic of study is magnitude of hepatitis C virus infection among asymptomatic Pakistani children. This study was conducted under supervision of Professor Dr. Rashid Zia. In the current era, viral hepatic infections, specifically hepatitis C virus, has become widespread and is the most important reason of liver diseases worldwide. WHO estimates that up to 50% of world's population has been infected with this virus. Hepatitis C virus is one of the most widespread blood-borne viruses and is related with momentous morbidity and mortality. It affects 170 million people worldwide and 2.4 to 6.5% people in Pakistan. The aims and objectives of the study was to determine the frequency of hepatitis C virus infection in asymptomatic patients that were admitted indoors and were presenting in OPD of Upstate Trust Hospital that were having no signs and symptoms of liver disease. A descriptive study. 1556 asymptomatic patients were added in the study. Those were attending the pediatrics department and they were selected on non-random basis. The age ranged from 6 months to 14 years were added in the study. Screening of antibodies against hepatitis C virus was performed through kit method first, and the positive cases were then confirmed by ELISA method. The informed consent was taken before the study and data was analyzed through SPSS 16. The results showed blood specimen of 1556 participants were screened for hepatitis C. Out of those 1556 patients, there were 602 females and 954 male patients were added in the study. After screening, 0.3 to 1%, there were 5 out of those 1556 were found to be seropositive for anti-HCV. There were 2 factors that were studied during this data analysis. The gender description showed there were a total of 1556 patients, out of which 602 females. Only 1 was positive and 601 were negative. There were 954 male patients, out of which 4 were positive and 950 were negative. The other factor that was studied was the age factor. The range of age from 6 months to 1 year were 20% positive, 1 to 5 years was 40% positive, and 6 to 10 years was 40% positive. Whereas the age range from 10 to 14 years, there was no positive patient found in this study. To conclude, data showed 0.32% asymptomatic patients had anti-HCV. These undiagnosed asymptomatic patients may be the basis of infectivity in the population. They are evading unnecessary blood transfusions and injections, and execution of strict infection control measures are highly recommended to trim down the frequency of spread of HCV infection. So these were the references used for the study. Thank you so much.
Next paper presentation, I would like to introduce our worthy professor, Dr. Awa Shabir, our distinguished and compassionate professor of podiatrics. With a wealth of experience in both teaching and clinical field that has endeared him to the students and colleagues alike. Sir's nurturing and fatherly approach has not only fostered academic excellence but also inspired his students to embark on meaningful research endeavors. Thank you so much, sir, for being a good guide, teacher, and mentor. Of Salto Liver on seasonal influenza in children under 5 years of age. This study promises to unveil profound insight that Assalamu alaikum to all the fellows and the respected professors and judges, starting with the name of Allah, the most magnificent and merciful. My name is Hafsa Asghar, student of final year MBBS. The topic of my study is the impact of Oseltamivir on seasonal influenza in children under the age of 5 years old in Pakistan. Starting with the background, acute respiratory tract infection poses a significant health burden worldwide, and influenza being the main key pathogenic cause responsible for about 20 million cases of acute respiratory tract infection worldwide. So we will be discussing the aim of study, mortalities associated with influenza, effect antibiotics. The main cause of deaths were mainly due to the delay in the initiation of early therapy. The aim of our study was to prove the requirement of diagnostic testing for influenza infection is not essential when it comes to the fatal decisions. Timely decisions for the diagnosis of the influenza enables the initiation of early therapy. And the third aim was to assess the impact of Oseltamivir both as prophylaxis and treatment. Influenza being the main key pathogenic cause responsible for about 35% of the cases in infants up to the 3 months and the 60% of the
cases in children from 3 months to 5 years. Symptoms of the pneumonia mainly include shortness of breath, cough with symptom production, chest pain. Incidence of pneumonia is highest in the South Asians with around 1400 cases per 1 lakh children. The burden of pneumonia is highest among the other diseases, which is about 35% as shown in this pie chart. Antivirals should be prescribed where the potential benefits outweighs the risk factors. Discussing the mechanism of action of virus, it has a neuraminidase enzyme and it leaves the salicylic acid residues from the surface of infected cells to promote the virion release. Now the oseltamivir, it is an antiviral drug, a neuraminidase inhibitor, is an effective treatment for influenza when it is administered within the 48 hours of the appearance of symptoms. Coming towards discussion, influenza causes a significant health burden leading to the high hospitalization rate and increased morbidities and mortalities. Due to the lack of influenza vaccine, it makes the oseltamivir the only treatment option in this age group. So, oseltamivir is recommended for children as young as 2 weeks old, but the grade-based dosing is required in order to produce the significant results. Under the age of 6 months, due to the lack of influenza vaccine is not recommended because of the reason the women who get influenza vaccine during pregnancy or the breastfeeding share the antibodies with her baby through the breast milk. As you can see, before the 6 months of the age, the antigen tolerance is there. This is because of the antibodies which the mother shares with her baby. After, the antigen tolerance starts to decrease as the age increases. So at this age of the 6 months, infants are highly exposed to the influenza. The first dose of the influenza vaccine is given at the 6 months, after which the antigen production starts to increase and so the TH response also increases. 3.5 mg per kg dose is effective in this age group. Coming towards the side effect of drug, it is mainly gastrointestinal in nature, which includes nausea, vomiting, diarrhea, abdominal pain, and the other effects, but these are very rare. The population study was mainly the retrospective cross-sectional study, and this study was conducted at the Farooq Hospital, Westwood. The data gathered for our study was mainly from the hospital directory and the patient files from the October 22 to April 23. Inclusion criteria. Children under the age of 5 years having the positive contact history with the viral upper respiratory tract infections, and those who opted the hospital admission for the management and showed the typical radiological appearances were included in our study. Whereas the children over the age of 5 years old diagnosed with a bacterial pneumonia and who didn't opt for the hospitalization and had the congenital malformation of lungs were excluded from our study. The main outcome includes the improvement in terms of the length of hospital stay. The differential leukocyte count in CBC was used as surrogate marker. The first CBC was conducted at the time of hospital admission and the final CBC was conducted on the last day of the hospital stay. The statistical analysis reveals that the p-value of less than 0.05 is statistically significant. Now coming towards the result, on the basis of inclusion criteria and exclusion criteria, total number of the population selected was 36, out of which 22 was included in group A and the 14 was included in the group B. The group A was the one in which oseltamivir was given along with the conventional therapy, but the group B was the one in which only the conventional therapy was given. You can see in both group A and the group B, the male ratio is more, which is about the 70%. As you can see in the table, the initial WBC count is more in the group A compared to the group B. This was because the group A had the positive contact history and has the more severe course of the illness. Now comparing the variables of outcome, in both group A and the group B, the length of hospital stay is more in the group A compared to the group B, but the final lymphocyte percentage in group A is less than as compared to the group B, which shows that the P value is less than 0.05, means that it is statistically significant. Basically, this is the graph showing the lymphocyte percentage, initial lymphocyte percentage, and the lymphocyte count at the time of discharge. You can see there is a marked reduction in terms of the lymphocyte percentage after the cytomegaloid therapy. You can compare the results with the group B, in which there is a very less improvement in lymphocyte percentage because there was no cytomegaloid was given. Results of our analysis reveals that the patient who were given oseltamivir shows the marked improvement in terms of the clinical status of the patient, but there was no significant improvement in terms of the length of hospital stay. Our study negated the hypothesis that it might be because of the two reasons. The first reason was the patient given oseltamivir were in the more sick condition, and the second reason was there was variation in the initiation of antiviral therapy. Limitation of study. Due to the population design, we couldn't ensure the large number of the population, and the effective use of other drugs cannot be negated. And the third limitation was there was difference in the initiation of antiviral therapy. But the main strength of our study was the antiviral therapy with oseltamivir can be initiated before the laboratory confirmation of influenza. Our study concluded the result that the use of oseltamivir was successful in improving the clinical status of the patient. Its use should not be delayed. If it is used within the 48 hours of appearance of symptoms, it shows a significant improvement in terms of the length of hospital stay. So that was all about my presentation. Thank you.
Thank you, Dr. Hauser. Now I would like to call Dr. Selina Muzaffer for the next paper presentation on the topic of the dilemma of ectopic pregnancy. Her presentation promises to unravel the prevalence, identification of the most and least common risk factors, detailed insight into the clinical presentation and terminology.
I'm Dr. Sunera, currently serving as a house officer in the Radiology Department, Palika Hospital. And today I have the privilege to represent this collaborative research between Radiology Department and our esteemed colleagues. First of all, I want to acknowledge the invaluable support and guidance of Professor Dr. Yasir Amin, Head of Department of Radiology, and Professor Dr. Naheem Jamal Faruqi for her guidance. The topic of my presentation is the dilemma of ectopic pregnancy, prevalence, most and least common risk factors, clinical presentation, and sites of implantation. This is the overview of what I will be covering in my presentation. Ectopic pregnancy. It is defined as the implantation of the embryo outside the uterine cavity. It is a common life-threatening gynecological emergency. It is the leading cause of maternal death during the first trimester of pregnancy. Worldwide, approximately 1 to 2% of all naturally conceived pregnancies result in ectopic implantation. The increased awareness and knowledge of risk factors have enabled an early and accurate diagnosis of ectopic pregnancy in the ambulatory region. Other sites include ovaries, cervix, myometrium, abdominal cavity, and interstitial portion of the fallopian tube. Mortality rates of ectopic are 10 times higher in undeveloped nations. Because of the improved resolution of uterine and adnexal structures, transvaginal sonography is recommended as means for detailed evaluation of patients. Use of high-resolution endovaginal sonography in conjunction with qualitative serum assays of beta-HCG allows detection of earlier and smaller ectopic pregnancies. Doppler techniques can complement with endovaginal sonographic findings, but they should be performed only after a real-time evaluation of adnexal region. Accurate diagnosis with endovaginal sonography is a prerequisite to non-surgical management. Our research was driven by certain objectives which were to determine the prevalence of ectopic pregnancy, to identify the most common mode of diagnosis for this condition, to explore the most and least prevalent risk factors associated with ectopic, to pinpoint the most common sites of implantation, and to provide an overview of the clinical presentation of patients with ectopic. The hypothesis of my research were the most common cause of ectopic pregnancy is a history of pelvic inflammatory disease. The most prevalent site of implantation in ectopic pregnancy Data collection was done through a pre-post format. My research span was 4 months from May 2023 to August 2023 at Farooq Hospital. It was a collaborative research between Radiology Department and Gynae and Obstetrical Department. Qualitative analysis method was used to produce the results. Now moving on towards the results, there were 1,500 women who reported with early pregnancy at the Radiology Department through indoor emergency, gynae OPDs or walk-ins, out of which 29 cases of ectopic pregnancy were diagnosed through ultrasonography. The mean age of the patients was 26.79 years. In our study, prevalence rate was found to be 1.93%, which was consistent with the previous researchers. We also observed the gestational status of the women, and in my results we found out that most of the women, 34.5%, were primary gravida. So this pie chart illustrates the mode of diagnosis in the ectopic pregnancy cases. There were 69% of the women who were diagnosed through transvaginal sonography, 28% of the women were diagnosed with abdominal sonography, and only 3% were clinically diagnosed. The most and least common risk factors for ectopic pregnancy. In my research, 31% of the women had a previous history of pelvic inflammatory disease. 28% of them had a history of sexually transmitted disease, and 7% each either had a history of intrauterine device, endometriosis, or any assisted reproductive techniques. And there were 4% of the women who had no identifiable risk factors. There were 72% of the women who presented with amenorrhea, 58% with abdominal pain, 41% with irregular vaginal bleed, and 6.9% of the women presented in shock. My results were consistent with a study by Astra AU in January 2022, which showed that common clinical presentations of ectopic were unstable vital signs, amenorrhea, abdominal pain, vaginal bleeding, adnexal mass, and cervical motion tenderness. In my research results, we saw that 62.10% of the females had ectopic in the right fallopian tube and 37.9% in the left fallopian tube. 27.6% of the females had unruptured ectopic and 72% of the females had ruptured ectopic. A study in Ahmedabad and in India both showed that most of the women who presented with ectopic had ruptured ectopics. To conclude my study, in our study, the prevalence of ectopic pregnancy is 1.93%. Most common mode of diagnosis was found to be transvaginal sonography. The most prevalent risk factor in our study area was found to be pelvic inflammatory disease and sexually transmitted diseases, and the least common was long-term smoking. Right-sided ectopics were more common than left, and the most common site of implantation was found to be the ampullary regions of the tube. Clinical spectrum of the patients with ectopic included amenorrhea, abdominal pain, irregular vaginal bleeding, and shock. Increasing awareness and educating women can help prevent sexually transmitted infections, and the risk of pelvic inflammatory disease can prevent serious complications and decrease maternal mortality rates. Before pregnancy, diagnosis and treatment of sexually transmitted infections and PID is vital. Thank you.
Thank you so much, all presenters. It's time for lunch break now, and after lunch there will be post-lunch conclusion ceremony in which sheet and certificate will be distributed.